Screening tests for prostate cancer come in a number of varieties. Most common and the easiest and the cheapest for anyone to do is a digital rectal examination. No patient likes the digital rectal examination, and patients will often refuse the digital rectal examination. Some people, I'm sure you'll tell me, Mario, don't want to come to your office because they're afraid you'll give them a digital rectal examination. There was one thing people hate more than a flu shot. It's a digital rectal examination.
Yeah.
So there enters the PSA. What is PSA? PSA is a blood test that was invented and widely used in the 1980s, and it stands for prostate-specific antigen. It's a marker put out by the prostate, and it's specific for prostate, but you don't hear the word cancer in that blood test, do you? Prostate-specific antigen is simply a marker put out by the prostate. Anything that causes inflammation will cause an elevation in PSA. So there's no one trigger level of PSA that should necessarily result in tests or treatment. But the higher the level of the PSA is, the more concerned we will all become. The general cutoff of 4 is used. However, for younger men, the cutoff is lower. For people at higher risk, the cutoff is lower. For example, a young Black man between the ages of 45 and 50 who has a PSA of 1.5 bears investigation. A young white man would need a PSA level of 1.5 at the age of 50 to 55 to trigger an evaluation. So it's age and race adjusted before we start thinking about what to do. But PSA is just the first step. Not all PSA elevations are cancer. In fact, PSA elevations up to 10, only 25% of those patients actually have cancer. So just because you have an elevated PSA is not the reason to become very alarmed or to freak out and think, oh my gosh, the sky is falling down. Most often it's something entirely unrelated to cancer, like kidney stones or prostatitis or infections of various kinds. And these are the kind of things that primary care doctors are very good at identifying and treating. Urologists sometimes get involved in that. Certainly anybody who has blood in the urine needs to be investigated by a urologist. That's something that requires urologic evaluation. PSAs higher than 10 should probably see a urologist, but the lower level PSAs generally can be repeated with a urine test, looking for other causes. And once those are ruled out, then we would consider further evaluation.
And Dr. Shasha, what's your opinion? Once I have a patient that we find an elevated PSA and we think that there could be possible prostate cancer, and I refer them for a biopsy, do you, and the patient, for example, does not want to have a biopsy, can they be monitored, or what's your opinion? Do every patient require a biopsy?
So because PSA is prostate specific and not prostate cancer specific, it begs the question, what should be the trigger for a biopsy? These days, while insurance companies don't like it, if we're really concerned about the possibility of prostate cancer, in particular, if the patient has a family history, they're African American, Latinos also have higher risk of prostate cancer than Caucasians, Asians have the lowest risk, but any man can have prostate cancer. But if we're really suspicious that there might be a prostate cancer, a good interim step to precede and even to direct the biopsy would be ordering an MRI scan of the prostate with contrast material that these days is very safe, rarely has allergic reactions, does not affect kidney function, and is a high resolution way of evaluating A, if there's cancer, B, where the cancer might be, so that if a biopsy is recommended, we'll know where to target. If the MRI doesn't show anything, the likelihood of having a significant cancer, as it turns out, is actually quite low. Mario, you know, as a primary doctor, you get a lot of patients come in with a lot of different issues. Urinary issues are pretty common as we get older. We men get older, you know, our prostates get bigger and it causes urinary problems. And, you know, we might be urinating more often at night, or the stream gets weaker, or sometimes we see blood in the urine burning. What are the sort of things that you see in your practice that make you think this patient might have something more serious, that you should send them to urologists? And specifically, what sort of thing brings worry to you that the patient might actually have prostate cancer?
So yes, so that's a very good question. So obviously, we always start with a good medical history. Again, the risk of prostate cancer, um, advances with age. Obviously, all men are at risk for prostate cancer, and definitely men that are older. The African American community, a higher risk. And again, we always get a really good history from the patient, whether they have extensive family history of cancers, including prostate cancer. In the outpatient, as far as the symptoms, we don't have a true symptom that can indicate a prostate cancer. We always some people might not have any symptoms and they can have prostate cancer. We always look at the general presentation, things that are involved with the prostate, for example, difficulty starting urination, weak or interrupted flow of urine, difficulty emptying the bladder completely, blood in the urine, as you mentioned, or in semen, back pain, pain in the hips, pelvis that does not go away. With cancer, we always look at unintentional weight loss, painful ejaculations. But again, none of these symptoms truly can be a sign of prostate cancer. So we look at multiple things, and that in addition to screening tests, and then that can lead us one way or the other.
Dr. Pinto, you've got a really busy practice. I know you see a wide variety of patients in your practice, young and old, African American, Latinos, all races. How do you talk to patients about screening? Who do you bring up the issue of screening to, and how do you approach it? And when patients are frightened or concerned about screening, how do you have that discussion with them?
Yes, thank you, Dr. Shasha. So that's a very good question, and we get it quite often in the outpatient setting. Prostate cancer should be an individualized approach. We always look at risk factors: African American ethnicity, family history of cancers, prostate cancer, but overall, it's an individual approach that should be discussed with your primary care doctor. Whether it's to do the PSA or the DRE or even a referral to the urologist.
That's great. And when your patients come to you and they're reluctant to talk about certain symptoms, how do you draw them out and make them feel safe that having an elevated PSA is not the end of the world? How do you provide them that reassurance?
Yes, we get that often in the outpatient setting, Dr. Shasha. And one of the things to note is that PSA is prostate-specific antigen. It's not cancer-specific. So a person can have an elevated PSA if they have, for example, a urinary tract infection. They can have an inflammation of the prostate or even enlargement of the prostate. So just because I let all my patients know that just because the PSA is elevated does not mean that you have a malignancy or a prostate cancer. We usually do a couple of steps further, do a little bit more history, and do further testing before diagnosing a prostate cancer. So yes, Dr. Shasha, I welcome all my patients to discuss prostate cancer screening, especially patients that are at higher risk, African American patients or patients with extensive family history of cancers or prostate cancer. And currently our cure rate, our mortality has decreased significantly. If caught early, prostate cancer can be addressed and be taken care of quite effectively, especially with the help of specialists like you, Dr. Shasha, and urologists.
What you say is very true. Having been in the prostate cancer space, treating patients now myself with prostate cancer since 1997, what we have seen is a dramatic decrease in the mortality rate over this time period. Back in 1997, there were close to 40,000 deaths every year from prostate cancer. Today, it's closer to 20,000. So in a span of 2 decades, we've had nearly a 50% decrease in prostate cancer mortality. And that is in a large part, I think, a credit to primary care people like yourself doing a great job screening, finding cancers early. The whole concept behind screening for any cancer is to diagnose it early before it spreads. Because we all know once a cancer spreads, it generally cannot be cured. So by screening, we find the cancers earlier, and by treating them early, we do a better job of curing them. At the same time, thank goodness, we've got phenomenal technological innovations on all of the various disciplines. So my own specialty is radiation oncology. At Nuvance Health, we've recently launched a new program of stereotactic prostate radiation treatment that condenses 9 weeks of radiation into 5 days of radiation, giving the same cure, the same side effects, but in 40 visits fewer. So it's really remarkable. The innovations are taking place, enable us to deliver higher quality treatment with fewer side effects, less cost, less inconvenience, and have improved cure rates. It's really a wonderful thing, and I'm so grateful for the partnership that we at Nuvance Health share with our primary care colleagues. So it's been a real pleasure talking to you today, Dr. Pinto. I hope we get to see each other again very soon and do this again. This was really a lot of fun.
Thank you, Dr. Shasha. I really appreciate you, and I will be referring my patients to your care.
We are here to help, and we will be referring our patients back. Thank you. You take good care.